Thank you all, and thank you to my gracious hosts. It's, of course, a real pleasure and honor to get to describe a little bit about what we do. We like what we do. We're very proud of it. And I think there are some lessons that can be picked up and shared internationally. So the context that I'd like to talk about is digital health and connecting these gaps. So when we talk about gaps, it's the question of what is this healthcare system we'd like to have, and what is the healthcare system that we do have. And so I'd like you to come with me for a minute into an alternative reality where I describe what we do have. And you can see from that and glean which pieces might be relevant for the future of healthcare here in Germany or in other places. So some of the gaps that we see is the notion of having a relatively healthy population, and they come and see their doctor now and then, and that's not actually what's happening, and that's certainly not what's going to be our future. People are living longer. There is going to be a sudden explosion of elderly patients who are going to have multiple chronic conditions, and the healthcare system is generally not ready for that. The physicians are generally not ready for that, and the patients themselves do not know what kind of conditions they will experience. The second, of course, is that healthcare is costly. I don't think anybody would prefer this to be the situation, but this is where we are. And that we, although in Israel we have spending relatively less of our GDP than other countries, in general it's not only costly, but it's growing in cost. And some of our understanding of digital health is to mitigate those costs, if not to reduce them, at least to reduce the size of the growth. And the third gap that we're going to discuss is the gap between what physicians expect from their experience and what patients expect from their experience. Some of that is the information. So physicians would like to have access to update recommendations, and patients would like to have support for the self-care that they're increasingly being expected to do. Second is an innovation, that we would like to introduce new technologies. There are some fantastic ideas from startups, from ground up, and they seem like they'd probably help, but we don't know exactly how they can probably help. We need to test their impact. We need to justify their cost. And the third is really in the communication. And Dr. Google is more than a joke. It really is an effect where there's an overlap between physicians and patients really trying to connect with each other, the messages that physicians would like their patients to hear, the messages that patients would like their physicians to hear, and the communication that physicians would really like to be able to do between each other. So can digital health really close these gaps? Is this the challenge of improving the quality of the care we provide, improving the health of our population, and reducing the cost? In this context, the proposal is digital health. And actually today I'm not going to talk about whether this is the best and how it could be done, but I'm going to fast forward everybody into the future where essentially it is being done. And I'd like to present a couple cases to describe some of the pieces that we do in order to take advantage. Because in a lot of ways, suddenly when you're there and you have this digital data and this is fantastic, everyone's happy, now what? And it's not clear the best ways or the priority of how to address them. So here we are. We are a very small country, and we have about 8 million people. 8 million citizens. I'm sure many people have heard of, or if not read, Startup Nation. It is very much emblematic of many of the things we do. We also have camels for many people who have visited. They do exist. We have signs on our roads warning for camels. We have agriculture. We have a tremendously strong agriculture. We have mountains. We have deserts. And to those of you who have visited, I hope you visited Tel Aviv, where I live. We have a thriving, internationally renowned city of dining and nightlife and education and culture. We have lots of different pieces together in this very small environment. The healthcare in Israel, I always face this, did not come about through intelligent design. It came about like every healthcare in every country, where it was an evolution of effects, both political will and political dynamics that brought it about. The way it stands right now is as follows. Essentially, every citizen must belong to one of 4 health funds. Okay? So that means that there's universal and mandatory coverage. And each of these health funds is funded, it's free. They're capitated with some age and sex adjustments. And they're given these funds and then told, go forth, please take care of your patients the best way you know how. And they're given a set of expectations that are agreed upon at the national level of what sort of services they must provide. And there are two pieces that are very critical to this that I think I understand. This is my audiovisual here. The first is, this is my national ID card, okay? So everything I do, essentially, from a supermarket to a bookstore to my taxes, is through my national ID number. And the second is my insurance card. So everything I do I'm in fact a member of Clait, I swipe my card, right? So when I see my physician, when I buy my medication, if I need to get imaging, when I gave birth to my son, I swipe my card. And that means two things. It means that one is that we are well aware of who knows what information we have. We are informed of that, but we also know that our physicians and our health insurance has all of our information. I said Clait, I'm part of Clait. It's the largest of the 4 health service funds. It has over half the population. This means that it has 4 million members. It is generalizable, right? So it runs the entire country, it runs the entire age span, and a number of years ago, about 2 decades ago, someone well before their time adopted a single universal electronic medical record. So the physician who sees patients in the south and the physician who sees patients in the north and the physician in the hospital, they all have access to the same system. And that means that all the inpatient, outpatient, pharmacy, lab, sociodemographics, clinical markers, and costs are all within a single database. And what we like to say is Clait very wisely stored these very carefully and for years did nothing with it. Because it's very scary to try to take a real live living database. This isn't a registry, this isn't a study, these are people's real information, and to start exploring it. But it became very clear about 10 years ago when our resources were getting thinner and thinner, and we were expected to do more and more because we have a very high life expectancy. I had to do it. I'm sorry. I did put the arrow of Germany, as I'm sure you've all seen this. And we began realizing that we desperately needed help, that we could not begin to manage our population and the expectations that we wanted to have without going in and starting to access this data and using it responsibly. We did have a hotbed of innovation and technology to lean back on. This is actually a delegation just from a couple weeks ago where we sent a number of startups, some of which are included here, that are specifically designed to support healthcare. We did have something to turn back to and use for support. And the Clait Health Services, which is this payer-provider system, founded the Clait Research Institute. And this was a shift in organizational mindset. The goal was really to take the excellent care that we wanted to provide, the mandate that we had to provide it, and to do it as intelligently as possible. So we take this data, we turn it into insights, and we turn these insights into our policy. Right? And so the research that we do include real-world outcomes. Yes, we know that medications are tested in general on a 70-kilo white male. How does it really work in a real population? We take models to actually look which patients are most likely to develop diseases, and we implement new measures back into our system. So the idea was that this way we could close the gaps. We could deliver the right intervention through our real-world effectiveness to guide clinical support at the right time. So we would be empowering our providers to intervene with preventive risk to the right patient, right? So this is integrating personalized medicine into clinical practice. And I'm going to run through about 6 examples of how we do these, and these are taken from a couple disparate areas. The piece that I want to emphasize is that Clait, which provides the medical services, is also the payer. So I know we're very special. Our incentives are entirely aligned, right? There's no pay for performance. In fact, there's as much interest as possible to be as efficient as possible. But more importantly, because we sit within the payer-provider system, the changes that we propose are introduced real time, right? This is Also, we publish papers, but we actually can influence the policy of the healthcare provider itself and then measure the effects of that introduction. So the first piece I want to talk about is adherence, and especially in diabetes, but in many other instances, adherence is really the holy grail. We know that we have some fantastic medications, and we know that many patients don't take them. And it's very hard in many cases when we have claims-based data to understand what is going on. And so in some of the research that we're doing, we found that even though we had anticipated that probably it would be the older patients who are perhaps less aware, less supported, who have less good insurance, less good adherence, we actually find that adherence improves over time. That actually the older patients are not the ones that need the gentle support, but it's actually the younger patients who are still getting used to a new diagnosis and need the support. And we also found that the effect of the disease duration really influences whether they were diagnosed at 50 or 55 or 65. And what has happened as a result is there are three projects that are actively being developed right now to target the populations that we identified and improve their adherence through multiple different measures. The next effect I want to talk about is readmissions. And so this is, of course, an issue worldwide, that we would like to think that the care that patients receive in a hospital when they need it is not going to result in them returning to the hospital, whether in 28 days or 30 days or however we'd like to measure it. And we know that there are some instances where patients will need to be seen again. But for the most part, we'd like to know that the treatment that they get is of high quality and of good use. We found that our patients, a couple things. We found that when we reviewed our database, we could see which patients are likely to return to the hospital. Not just which types of patients, which actual patients are likely to return to the hospital. And we could reach out to their primary care clinic and have their nurse at the clinic reach out to them and contact them after they were discharged from the hospital. This requires a system that's connected, right? So this requires a connection of information from the inpatient system to the outpatient system, and someone to monitor the data to identify which patients are at the highest risks and should be reached out for. The next I want to talk about is prevention. So we do this a lot. This is one of the more gratifying pieces of work that we do. We take our data historically. We have, in some cases, about 2 decades of data, but we certainly have a good decade of solid data available. And we look back in time, okay? And we take patients as of a certain day that were disease-free, and we follow them for a couple years and see which ones develop a disease. We take those signals, and I'm not talking about signals that a good doctor with adequate support would detect. I'm talking about small signals. Still, their values are within a normal range, but small changes over time that a reasonable doctor would not pick up on, but that a reasonable medical healthcare system would. And we flag them to the physician. Right? We don't tell the physician what to do, but we flag them and we say, this patient is at high risk. We've learned from the history of our data that within 5 years, they have a 10% chance of going to need renal replacement therapy, whether dialysis or transplant. We would like you to follow them. We would like you to bring them in. And this was received with enormous excitement from all sides, that the patients were excited that someone was following them and knowing what was going on. The physicians were excited to have support, right? This wasn't a command to control. This was a support for the physicians who might not be able to go through every lab over the last 10 years. And for the organization, this was outstanding, right? Renal replacement is exceedingly costly. And if the idea is that we could prevent through an early identification of patients at risk, everyone goes home happy. I want to talk a little about ranking risk, okay? Because I think this is something that, this is when the management of a healthcare organization really becomes a critical component. We, within our data, right, we can create predictive models to understand who is going to be at risk. And we can then assign each of our patients from 1 to 4.3 million, a risk score, okay? And we can rank them. And then we can turn to the management and say, In this example, this is meningococcal disease, for which there is a vaccine that is very effective for the more invasive types of disease. We can say, we know we have limited supplies of the vaccine, and we know we have limited ability to push it on our patients. How many do we want? We want 10,000? We can tell you the 10,000 patients in our system who are at highest risk. If next year we have 13,000, we can tell you the top 13,000. And it's an iterative process. It's a conversation between the patients who are at risk, the physicians and the providers who are accessing them, and the management who is supporting it. If they'd like to choose instead the top 5%, we can tell them how many patients that would be. And we can run through each of the various form models. And this makes our data infinitely accessible, right, to both the patient and the provider and the management system. The next piece I want to touch upon is disparities. And so we're a large organization. We have over 14,000 clinics. We have 14 hospitals. We can't possibly, nor do we want to, actually monitor everything that goes on within them. But we can take the bottom performers and try to bring them up. And so what we did is we took preventive scores such as mammography rates, immunization for influenza rates, and we took the bottom performing clinics, and we went into the clinics as an organization and said, what are you missing? What are you lacking? Is it communication with the patients? Is it evening hours? And we were able to provide them with pointed and effective integration of care such that we essentially eliminated the gap between the upper performing clinics and the lower performing clinics. So this was identified through data and implemented through a connected healthcare system. The last piece that I want to touch upon is targeted intervention. So actually, I just want to touch on the left. This is resistant cases of a certain bacteria and total antibiotic use. Okay, and you see this is at the countrywide level, total use countrywide level. And this is helpful. This tells us there are some countries that have, essentially the more antibiotics you use, the more likely you are to have resistance. And you can see probably there's some similarities between different countries. So we take this and we granulate much more deeply. We go through each antibiotic that is prescribed within our healthcare system, and then we go through our 8 districts and look at the age-adjusted rates to those prescriptions. And we can pinpoint, we say, wow, in this one district, they are prescribing this antibiotic at much higher rates. We can reach out to those and try to understand, does it fit with the binorm? Does it fit with the distribution? Are there certain physician practices or hospital practices that are very much outliers and are over or under prescribing certain ones? And we do it, I want to say, because we don't have pay-per performance, it is really, we need to have the buy-in of our physicians when we do this. And we need to help make sure that what we're doing is an element of supporting them and not policing them. So I want to talk as we finish up sort of the cornerstones of how we use digital health. And so a piece of it is this ongoing evaluation, that the data that is being collected on our patients is not just sitting in a box in an empty room, but that there's an ongoing interest and in-depth evaluation of what it means. That the decision-making is not being done at an abstract level, but is actually relevant to our patients, for both our patients and providers, that makes them feel both involved, and it makes them involved. It makes it relevant to the work that we do. That the research that we do is policy-driven. This is a critical point, and this is the only reason that we are allowed to exist. We are not an academic center. We are not turning out papers just to turn out papers. We are doing the work that we do in order to improve the care we provide. And every single research that we do goes through several committees to ensure that it is actionable research. And I think that really helps, us sleep well at night, but it helps us as a country sleep well at night to know that our data are not only secure by technological methods and passwords, but that the intent is consistent with what people would want. And I think the management component is really clear here, that the role is not to jump in and hold some guidelines over a physician's head, but instead together develop the guidelines in concerts with the needs of the communities and provide them as support, whether it's a pop-up or a flag, but not to do necessarily individual physician performance reviews. And this way we maintain the buy-in. Our physicians really actually appreciate the support we provide. So the new frontiers, and I always stumble upon this a little bit because the digital health that we have is very much at the black box level, where we take the data that are collected and we work with them. But we have not yet integrated, for example, patient-reported outcomes. We've not yet integrated self-care. Telemedicine is something that is largely touted as a possible solution for issues of supply of physicians and issues of physicians in the periphery. This is not something that as of yet we've studied. Wearable devices, whether or not physicians are interested in them, they certainly exist. People certainly seem to like them. What that means, I don't know. And some of the home monitoring, whether for our elderly patients, having home monitors is going to be one of our solutions to managing their chronic conditions, as well as other new sources of data that I can't even imagine. This is, I think, for sure where we are heading. I don't yet know how we are going to deal with it, but I do think that the basis that we build in terms of how we expect to use our digital data is going to provide us with the elements of how to deal with the new frontiers. And again, I want to thank you. I hope that this provides a taste of some of the exciting things we do and a source of conversation for the topic of the day of digital health.
Yeah, thank you very much, Maya, for getting us an insight how this system is working. This is, in fact, very much top-down organized. It is really, in a sense, taking care of the community. And I liked also very much the last slide where you presented, well, these are the next steps. But one of the key things is, in a sense, it's built around a system and not as island solutions here and there. So the question what we are facing also in Germany, does it add any sense, in a sense, to put a little piece here, a little piece there, without having a system on which it is, in a sense, plugged in? We have time for a couple of questions. You could put them either in German or in English. Who goes first? Yes. You have to press it.
Nicholas Hus, I'm working for Startup Bootcamp as a startup accelerator. We're starting here in Germany with a healthcare program. My question is, you showed that you are using digital health for show some new figures about research using digital health. You have a very innovative startup environment in Israel, but how you bring in these new ideas within the system?
So, if I understand the question correctly, right, there's the innovation that we do internally, and then there's the innovation that happens in the rest of the country. And the question becomes, which of those startups are we going to do one of two things with? We are either going to embrace them at their early infancy stages and help them grow within the context of the organization, or we're going to wait on the sidelines until somebody else irons out all their issues, and then we'll happily incorporate them. And we do both. So there have been some, especially management of medication reconciliation and prescriptions that were essentially born within Clait by Clait physicians who developed it with the support of our organization, and then as a result actually had a very successful marketing worldwide. We do this within our umbrella organization where we do fund and support certain startup innovations internally, and we separately work with a number of different startups in concert who come to us with an idea that they'd like to prove. Okay, so it's less of telling them what their idea should be, and it's really letting people say, you know, hey, we've got this fantastic idea for medication adherence. We think that if we use this app in a certain way, people's adherence will improve. And we say, fantastic, are people already using this app? Yes, it's out there. And we say, great. We have the opportunity to merge the data with ours. But that being said, we are very clear that we are not, we don't want to, we're very proud of the fact that our interests are aligned. And we would not like to threaten that in any way. So in many ways, when we do provide these supports for startups who have not yet proven themselves, it comes within the context of sort of existing innovations that we can essentially provide the clinical background to. And I'll expand that even further, not just within our home country, but when we work internationally with other organizations as a collaboration center, we do the same idea, right? So we take our data and we do our best to match it with existing data to understand, to provide the complement of other data sets that don't exist elsewhere. But I will say we do not think of ourselves as a playground for innovation in other contexts, because we find that the reason that we do what we do so well is that we take our patients as our number one priority in terms of improving their care. So it's always a balance between not missing a new technology or a new idea that's really going to improve their care, but also not putting their care at risk by taking a chance on the new technology.
Further question? Yes, Birgit Bender.
Thank you very much for your inspiring presentation. My question is whether you use some kind of patient involvement, patient participation in developing new ideas. And I'm asking the question because in Germany, people tend to be very suspicious if somebody else works with their own personal data.
Yeah, so we do, I would say we do three things. One is there's a nationwide survey of people's satisfaction with their healthcare for all health funds, and that is publicly available information. So patients know how the other health funds are performing, essentially based on the patient experience. Number two is we do have a website where patients have access to their own data. So when you have a blood test done, you get a text message, says it's available, you log in, and you can actually see what your numbers are. You can print them, you can put them on Facebook, you can do whatever. It's your data, and people do. So I think that really empowers them to feel like it's not somebody else's data, it's my data, and I can access it. And it's even a step further. I have my sons are on my website, right? So when I want to see when their next visit is or what their laboratory value was, I can go into that. And I think that's very empowering for patients. I think the third aspect is the area of patient-reported outcomes. And so this is not just saying what do patients think about the care they provide, but what kind of results are they seeing? Not just the ones that I as a physician think they should see, but they had the surgery. I feel confident they didn't have an infection, but did it improve their quality of life? If that was the goal, then we need to know that. And so that's sort of the frontier that we're adjusting now is how do we introduce patient-reported outcomes as a system, and how do we capture that data to be able to measure it? We're doing that. I think it's clear to me it will happen, and it's clear to me that it will take some time to happen. And it's also clear to me that patients really value the opportunity to speak up within that context.